Good evening, everybody, and once again, welcome to Accelerating Orthodontic Treatment. I'll be your host this evening for this webinar. My name is Dr. Gary Brigham, speaking to you from Scottsdale, Arizona. Just a little bit background on me. I'm currently serving as a dedicated Invisalign and Propel instructor and Adjunct Professor at AT Still Orthodontic Graduate Program. I'm also serve on the Clinical Advisory Board for Propel Orthodontics. In addition, I have a bit of an Invisalign background. I'm a top 1% provider, and we're just over 1,855 cases treated with almost 600 Invisalign teens. I'm currently serve as a member of the line faculty. I also serve as a member of Your Ortho Coach, which is Dan's specific one-on-one coaching program. Currently, with my own experience with accelerated products, we've done about 208 manual osteoperforation cases, and we just topped just slightly over 100 high-frequency pulse vibration cases. I've published 3 articles on manual osteoperforations and pulse vibration devices in orthodontic practice. And I have to offer this disclaimer that I've been compensated for it. And specifically, what I'm sharing with you is my own experience with these devices, and the opinions that I'm expressing are mine alone. And I hope that I can give you some benefit just sharing my experiences with accelerated orthodontics. So Tom Pitts is someone that I've always looked up to and followed him for a long time and learned an awful lot from him. And he's always talked about exceptional aesthetics with his orthodontic treatment, and which is remarkable. But more recently this year, in one of his advertisements for one of his seminars, he's now talking about not only exceptional aesthetics, but also doing it in less time. And I think everyone who's gone to the summits knows that at the last orthodontic summit for Invisalign, Invisalign has announced the change to exchanging aligners in 7 days rather than the traditional 14-day aligner exchange. And even Colgate's got into the picture. One of their most recent advertisements on their oral health network is talking about the fastest way to straighten teeth without orthodontic treatment. So why this collective focus on accelerated orthodontic treatment? What do they know that so many orthodontic practitioners are already experiencing interest from their patients in acceleration, but don't yet know it will likely be an integral part of their future orthodontic practices? Well, I think whether practitioners realize it and accept it or not, and regardless of the modality of treatment that they're using, I think a principal focus in the future is going to be placed on accelerating orthodontic treatment. And why? I think historically, changes in orthodontic treatment methodologies have often been driven simply by patient demand and patient concern. And over the past years, anybody that's been practicing for a while in orthodontics knows that there's been a noticeable shift in teens' attitudes towards orthodontic treatment in general. And specifically, they still all want perfect smiles, but with their schedules and with their social media identities, I think these teens now just don't want to stand out while they're getting these smiles. And more importantly, now they'll give you about a year to get it for them. After about a year, you'll see a precipitous fall in their capacity to cooperate and to follow through with the instructions that are necessary to achieve good orthodontic results. And sociological surveys further indicate that millennials and baby boomers alike are now mimicking teens in their diminishing capacity for both patience and compliance with orthodontic treatment. So it seems to be like something that's spreading across the country. And I've noticed a significant trend just from the past 7 years. So now more than anyone time before, orthodontists today are now faced with increasingly new and challenging treatment time constraints that we didn't have to deal with 10 to 15 years ago. And currently, the current acceleration treatment modalities that are available are manual osteoperforation devices, pulse vibration technology, and also low-level lasers. And I'm going to direct my attention specifically to MOPs, manual osteoperforations, and to the pulse vibration technology that's available. So accelerated orthodontics is creating, in my opinion, a paradigm shift in the manner in which patients are being treated. I think, just from my own experience, the combination of clear aligner therapy and MOPs has the potential to change the face of orthodontics as it's currently practiced. And I think it's important that anybody that uses any type of acceleration device to have at least some generalized background of the science behind acceleration, because there's a lot of controversy with regard to it and a lot of disagreement. So, and the reason why it's important is when you're presenting accelerated treatment options to patients, I think it's important to be clear on the science in which it's based and be capable of explaining it to patients in terminology that they understand. So, research suggests that acceleration's effects begin with osteocytes, and that really makes sense because osteocytes are the mature cells and bone cells, and they also happen to be the most ubiquitous bone cell in the entire bone or skeletal matrix. Osteoclastogenesis specifically requires inflammation in the area, and MOPs mechanically disrupts osteocyte cell membranes. And you can see there's a lot of osteocytes hanging around with the osteoblasts and the osteoclasts in the bony matrix. Mechanically damaged osteocytes secrete a number of pro-inflammatory cytokines and chemokines, including MCSF and rankle, that activate osteoclast activity. And I'm going to be a little bit more specific about this very shortly. Now, I've searched all over the research, and still to this date, and I showed this in my last webinar, to date, this is still the most comprehensive and easily followed diagram trying to explain the difference between MOPs and pulse vibration, even low-level lasers. And specifically, pulse vibration can result in the secretion of MCSF, but it's a long route to get there. Whereas MOPs, as soon as you do some tissue damage, you get this flood of MCSF as well as rankle, where specifically with these modalities, it's mostly rankle. And the bottom line is this: when there's a flood of pro-inflammatory cytokines and chemokines, it stimulates these osteoblasts to release rankle. Rankle is just simply a protein that sits on the cell membranes of osteoblasts. And once it's released, it seeks its receptor site in rank, and these receptor sites usually are on monocytes or macrophages. And once they connect, it stimulates these mononuclear cells to combine to start forming mature multinucleated osteoclasts. Once you get a multinucleated osteoclast, now you've got an osteoclast that's beginning the bone modeling process. And that's basically what it comes down to. That's the science. Now, the formation of osteoclasts is regulated by a formidable number of cytokines. And although there's an awful lot more than what I've got right here, there's been more research to elucidate that there's always a flood of these when there's osteoclastic activity. Specifically, I think these are the most important ones because there's the most information with regard to MCSF and rankle and OPG. Now, the rate of bone resorption can be regulated by increasing the number of osteoclasts and increasing the activity in survival osteoclasts. And this is very important when it comes to bone remodeling. And specifically because MCF is an important cytokine. And it's important because mechanically induced tissue damage stimulates MCSF-dependent bone marrow macrophages to differentiate directly into osteoclasts through a mechanism that's completely independent of this rank-rankle interaction, which I previously discussed. So now we've got a cytokine that can actually do an end run around this interaction that goes on with osteoblasts that releases rankle to hook up with monocytes that have the rank receptor and start converting into osteoclasts. So MCF is a particularly important cytokine because it rapidly and potently augments rankle-induced resorption. It dramatically stimulates osteoclast motility and spreading, and it enhances osteoclast survival, migration, and chemotaxis. So just on the basis of these three things alone, MCF is a very important cytokine when it comes to MOPs. Literally, it appears that MCF just serves to caffeinate osteoclast activity. It really jacks it up to a level that normally isn't seen with something like pulse vibration technology. Pulse vibration, on the other hand, appears to, it doesn't damage osteocytes, but it appears to create tension within osteocytes that stimulates their release of pro-inflammatory chemicals that generate the release of rankle. So what's the difference between these two modalities? From what I can glean from the research, it appears that MCF plays a very integral role in stimulating osteoclastic activity with MOPs. And the benefits are clear. With MOPs, You can do a 3-day aligner exchange instead of the 7-day aligner exchange that is being promoted right now. And my personal experience is that it greatly enhances aligner tracking with it provides the greatest predictability in your results. Now, pulse vibration on the hand, it seems that MCFF does not appear to play an integral role in stimulating osteoclastic activity. But the benefits nevertheless are clear also. You can still exchange aligners anywhere from 5 to 7 days. And my experience with pulse vibration is I think it enhances aligner tracking with more predictable results than I get just simply exchanging aligners every 7 days without the use of any vibration device. With the MOPS administration protocol, it's very simple. It's basically 3 steps. You evaluate the treatment area either through palpation or evaluating your panelips for root position. You get chlorhexidine rinses 2 times for 1 minute each, pre and post manual osteoperfurations, and you anesthetize and accelerate. You accelerate with the BTT, and you can see what BTT consists of, and it's with a profound topical, and or you can also accelerate your an anesthetic by just doing a very mild local infiltration in specific areas. And so this is what I do. I use the BTT, and when necessary, I back it up with a little Septicane. And then you go ahead and perform your MOPs at depths that are anywhere from 3 to 5 millimeters in depth. Propel actually offers you a great procedure checklist, and I used to use this when I was first beginning MOPs and follow this, and it was very helpful for the staff. It's just a 1 sheet, and I'd recommend if you're just beginning to embark on using MOPs, that this is it's very explicit, it's very simple to follow, and it's a very useful tool. And same thing with the mapping out where you're going to put your perforation sites, and I'm going to show you how I used it at the beginning, and sometimes I still use it when I'm trying to communicate with my staff in preparation for it. And it still has the checklist for making sure you get the informed consent, make sure you get the chlorhexidine rinses, and make sure that the patient is using Tylenol and not Advil for their pain. We make sure that that's repeated on several occasions before they actually come in for their MOPS appointment. Now, it's important to consider the morphology of alveolar bone when you're planning out your MOPs, because the cortical plates of alveolar bone consist of compact bone, which varies in thickness in different areas. So, for example, it's thicker in the mandible than the maxilla. I think everyone knows that. And it's thicker in the premolar and the molar region than it is in the anteriors. So in the anteriors, it's usually about 1.1 to 2.8 millimeters in thickness. And in the posteriors, around that region in the premolar and molar areas, it's 1.5 to 3.3 millimeters in thickness. And then in the alveolar bone, just between the first and second molars, it tends to get a little thinner again. It mimics more the thickness of the bone in the anteriors. And then once again, cortical plates are thicker in brachiocephalic and thinner in dolichocephalic facial architectures. And so this information is very good to have as you're approaching your MOPS patients. So the depth of penetration necessary to initiate osteoclastogenesis has been met with uncertainty due to a lack of research. There is some research out there, and in my own personal opinion, I think Alicani's definitive MOPS study, where he showed some significant success with tooth acceleration, when I read the paper, it seemed that he only did a 2 to 3 millimeter depth. So once I read the paper, I backed off on the 5 to 7 millimeter depth. And I find that I'm just getting the same type of acceleration results by going 2 to 3 millimeters. And the research suggests that since there's a fanning out effect with the cytokines and the chemokines, that all you have to do is disrupt the cortical plate of bone. And once you do a little damage there, that sets off this offspring of chemicals that fans out and gets the result that you want in terms of osteoclastogenesis. So as I'm doing more MOPs, I'm becoming more conservative with regard to my penetrations. And it's also important to know that when you're doing your penetrations, and right now I'm just using the accelerator PT, it's important to direct them as perpendicular to the bone as possible to get the most efficient penetrations. And it's also important to be cognizant of the fact that the morphology changes, especially in the maxilla. So I found that if I'm going in with the accelerator PT and it doesn't seem to be penetrating, then I just simply back out, reorient the device, and to get it as perpendicular as I can to the MOP site, and then engage the alveolar bone. So if you're not getting some engagement within the first 3 seconds, and you feel like you're bouncing off of it, just back off, reorient, and re-engage, and you'll find that you'll be a lot more successful that way. So now with this new aligner MOPS treatment protocol, I'm doing things completely different from what I did without MOPS. So it used to be at the first appointment, I just delivered the first aligners and then sent the patient on their way. And now what I'm doing is I'm applying the attachments to one or both arches, depending on how much time the patient has in the chair. Conduct as much IPR as we possibly can, and we spend a significant amount of time reviewing the tracking of aligners with patients, and I'll show you how we do that very shortly. Then we instruct the patients to take 1,000 milligrams, that's 2 500 milligram tabs of Tylenol, approximately 1 hour prior to their MOPS appointment. And we also instruct the patient that they will experience some sensitivity 24 to 48 hours following the procedure. I tell the patients, don't get me wrong, you're going to be a little miserable that afternoon. The next day, you'll be a little achy on Tylenol, and the third day, you'll be absolutely fine. And I've never had a patient say that that was not true. And with this new protocol, it's especially critical that patients be able to identify good tracking before they leave the office. Because with clear aligner technology, it's all about good tracking. And this is what we do. We have these cards in the office in every cubicle, and they're rather large, so we can be very clear to the patients upon the instruction. And the top portion of the card, it's a large photograph that shows what good tracking is. And on the bottom portion of the card, we've exaggerated poor tracking, so it can be very clear. Tell them we don't want to see any daylight at the edges of these aligners. We want to make sure they're clear on understanding that, because that's the whole essence. We always point out to them that the teeth that are going to likely untrack is the lateral incisors and sometimes canines in severe rotations. So we tell them to focus on that. And that determines how they're going to flip out their aligners. At the second appointment, regardless of whether they're using a hand device, which we used to use, and as I said before, we now use the accelerator PT. But regardless of the device used, the treatment protocol is always the same. You review the procedure with the patient, a secure written consent form. You have them sign it, then you have the patient rinse twice with the chlorhexidine. You apply the BTT and the local infiltration with the Septicane if necessary. Let them sit for 3 minutes in suction. You review the MOPS treatment location sites. You activate the device, and you begin the MOPS. You ensure the patient before they leave is clear on identifying proper aligner tracking. Our normal protocols to deliver 10 aligners, instruct them to exchange the aligners every 3, 4, 5 days according to their tracking. And normally with MOPS, we see them in a month after 10 aligners. They're usually right on schedule with exchange the aligners every 3 days. The setup is absolutely easy. You've got the BTT, the chlorhexidine. We have a timer so we can time. What we've done, we've take 2 gauze sheets and we put them, we fold them over vertically. So what you're looking at here is 2 gauze squares side by side. Take the BTT and just push it right across there. A nice big fingerful of it. And then we apply it directly to the tissue. And then my auxiliaries, they just go ahead and take a Q-tip and just tuck it in interceptively in between the teeth. And we've got a little mouth guard there, just to make it as easy as possible. You can see it's not sloppy, nothing dripping. It makes it very easy to use. And it's hands-free. You can see it stays in place and it applies. We've got the timer for 3-minute application. And after that application, you simply remove the gauze and you suction. Then we go ahead and test the effectiveness of the anesthesia. I just use amalgam plugger and just go interdentally to make sure that the patients feel pressure but no pain. And once it's obvious that they feel pretty good with the guard, then they're ready for the MOPS. And we go ahead and we initiate the perforations. It really is that simple. It's that clean. And like I said, I'm not going in more than 3 millimeters. I'm just going in there to disrupt the cortical plate of bone. And you can tell you get a little hemorrhaging, and usually is adequate enough to get the desired frequency that we want in terms of flipping out the alignments. And you can see it's not really out of control. These are very simple perforations. Uh, when I first started this, I did 3 for each tooth. Now I'm only down to 2. If I have an exceptionally long canine and I want to really get a lot of distal root tip or change it one way or the other with axial inclination correction, then I'll go 3 on each side. But that's the only. It's usually just 1 in front of the molars, and it really. When I first started this, it was taking me 45 minutes. Now you can really go through this in 15 to 20 minutes, and that's going 6 to 6 in both arches. So let's just go over 1 or 2 cases. This is a 19-year-old with a vertical class 2 malocclusion, and she'd been 4 years out of fixed appliance therapy. And she said she'd been wearing these vertical elastics, and she said she and the orthodontist got tired of it, and they decided to leave it as it was. But she came back in the office because she started getting headaches, and obviously you can see that she's got a recessed chin point from her vertical class 2. She has inadequate incisal guidance, a little proclination of the maxillary incisors, and she wasn't happy with her dark buccal corridors. But she had very acceptable incisor display. And you can see she's definitely a vertical class 2, which was 6.7. She had an incisal guidance that was not within the physiological range. That interincisal angle is way too obtuse. The facial axis was very poor, 77 degrees. And the goniontognathon perpendicular was way off base at minus 7.4 millimeters instead of the minus 2.2. And with regard to axial inclinations were not unreasonable, simply because she had previous six appliance therapy. And so the treatment plan was to use Invisalign Teen and intrude the posterior buccal segments, which is the maxillary molars and bicuspids, and mandibular first molars and second bicuspids. The key to treating these vertical class 2s is just to incorporate a very gentle curve of speed. Incorporate that into ClinCheck and have it express itself clinically. And by doing that, we can generate a hinge axis of closure of the mandible in ClinCheck to effect an acceptable overbite that establishes incisal guidance without extruding the maxillary central more than 1 millimeter. And then to also broaden the arch form, and you can do that with clear aligner therapy without worrying about opening up the vertical anymore. One of the treatment goals was to create an acceptable smile arc and to improve patient profile by getting a little bit more projected the chin point via the hinge axis of closure of the mandible, and to support the intrusion mechanics with MOPs and with the patient use of rubber gum. So this is what the ClinCheck looks like. Now, I want to be very clear so there's no confusion with regard to this ClinCheck. As I mentioned previously, I teach orthodontic graduate students at the AT Still Graduate Program, and so I specifically asked that this ClinCheck be broken down. It wasn't expressed like this clinically, but I broke it down because I'm trying to teach the students the Nicosis extrusion protocol for the interiors to create the smile arc, and I also wanted to show them Dayan's protocol for extruding the posterior buccal segments to incorporate a nice smile arc. So what you're going to see is a breakdown. What you're seeing is a breakdown of the Nicosis extrusion protocol to get the smile arc in the interiors, and then you're going to see the intrusion mechanics to get the hinge axis of closure. But I want to emphasize that this wasn't broken down like this clinically. These things were both the extrusion of the interiors and the intrusion of the posteriors were happening simultaneously. I just had asked this to be broken down for instruction purposes, but it helps in this particular webinar too, so you can see. You can get an idea of, and this is the reason why there's so many aligners, because when I'm trying to incorporate a smile arc in these patients, I slow down the velocity of tooth move to 0.15 millimeters per aligner to maximize the opportunity to get the best extrusion and the least amount of untracking that I possibly can. And I found that this approach is the best approach that I can. And when they untrack, then you've got to go back to bootstrap elastics. And I'd rather avoid that if it's possible. And this has given me the greatest degree of success. And once again, you can see it from the right. There's the Nicosis extrusion protocol for the interior, the smile arc. Then you'll see the intrusion mechanic to incorporate the curve of spee. And then you'll also see, as these teeth are intruded, that you'll get that hinge axis closure of the mandible, and hopefully a reasonable projection of the chin point to reduce that or to improve the profile. Now, to ensure that I'm maintaining the incisor display, I always use the grid because the grid's great. And so I don't want to, every box on the grid is 1 millimeter, so I don't want to see any more than a millimeter of extrusion of the central incisors. And this is the way to test it. And with the NICS extrusion protocol, it states that for every 0.1 millimeters of extrusion, you have to have an equal amount of protrusion. And that's what you're witnessing in this particular clinch. And you can see we just about got not more than a millimeter of extrusion of the maxillary incisors to preserve that incisor display that we like. And this is what it looks like. This is how we used to, and we still do to a certain extent. We plan out our treatment, and for the central incisors, just use 1 MOPs. Did do on each side. I didn't have to do much axial inclination on the canine, so I thought that was fine. The lower, just did 1 perforation. So this is how you map it out. Now, since I'm doing maxillary intrusion of the buccal segments, I'm actually going behind the first molar and getting a perforation between the first and second molar because I want to get this bone ready for exceptional osteoclastic activity to maximize my chances of success of intrusion. And I want to do this at a velocity of flipping out these aligners every 3 millimeters. Now, this was usually a challenge with the manual osteoporation devices, but now with the Accelerator PT, this is not a problem. I can go in there at an angle, and I can still get the perforation that I need to affect the treatment that I want. And you can see perforations are, I'm only doing 1 perforation on the lower, or 2. You can see that I'm doing 2 perforations all the way into the back, and just 1 perforation in front of the molars and between the molar, the first and second molars. And then this is, in order to augment the intrusion mechanics, we're using rubber gum, and rubber gum is simply the rubber stems from the O-rings that we use to tie, and the colors that we use to tie in for fixed appliance therapy. We save those, and then this is how we use them. And we tell the patients that rubber gum therapy is not part of their treatment, is their treatment. It goes hand in hand with the aligner treatment. And after 49 aligners, we're able to meet all of our treatment objectives with no refinement at 7 months and 3 weeks of treatment. So anything that I can do to accelerate beyond the 7-day aligner exchange is always a plus, because at this particular point, the patients oftentimes are already getting just a little bit burned out. So I want to do everything I can to meet these objectives. And with MOPs and the use of rubber gum, we are able to meet our objectives. And I really feel that we've got a little bit more chin point projection here, improvement in the facial profile. Reduce the width, which is still a class 2, which always will be unless you had jaw surgery. But we got the interincisal angle back into the acceptable range, which is 125 to 135. Even close the facial axis just a mite, and we significantly improved pogonion to nasum perpendicular. And from what I can see, I think that the roots are doing fine, and they look just as when she began treatment, and so we're pretty happy with that. Here's another case. Got an orthodontic graduate student. He was graduating in 10 months, and he decided that he needed to do something since he was going to be out in the public with his peg-shaped laterals. So he's a brachycephalic class 1, width of 1.7, so just a little outside the class 1 range. Interincisal angle is too obtuse and not within the physiological range. The lower mandibular incisor MP is just a little proclined. It's got a good facial axis, and the maxillary incisor to nasion is just a little proclined. So what we really need to do is we need to steepen that interincisal angle, and we need to plan out for recontouring of those maxillary lateral incisors. So the treatment plan was to develop the arches to a broadened arch form to fill his buccal corridors once again, and to use a Bolton analysis as part of the treatment plan to plan out for composite recontouring of his peg-shaped maxillary lateral incisors. We wanted to retract both the max and mandibular incisors to steepen the incisal angle to get it within that physiological range, and to conduct at mid-course correction composite buildups of the maxillary lateral incisors. We wanted to create an acceptable smile arc, and we wanted to support the arch form development and the creation of a smile arc with MOPs. And I told him since we were going to stop in the middle and build up the lines, I was going to take 2 separate MOPs experiences. What I really appreciate about having the Bolton analysis is that that's how you do the planning, because the peg-shaped laterals were just slightly different in their width. So what I wanted to make sure is that the width of the peg-shaped laterals plus the distance, mesial and distal, the spacing, was equal to the contralateral sine. So when we were finished, we had some degree of symmetry with regard to the cosmetic buildup. And that's the great thing about planning with using ClinCheck. And so for this first round, we've got vertical attachments. We're going to get 45-degree gable bend so that we get some good root parallelization in this particular ClinCheck. And we've got some horizontal beveled attachments to get as much gripping power as we can on these peg-shaped laterals and get them spaced as evenly as possible, as close to the planning that we've had, so that we can stop in the middle after 28 aligners. And you can see what this looks like from an occlusal standpoint, where the teeth have to come out and then come down a bit. And we're broadening the arch form a bit. See, we're getting some axial inclination, some rotation correction of the canine. And we've got some space to close on the right side, distal to the canine, mandibular canine. So we're using a vertical attachment to maintain the axial inclination of that tooth. And as I said before, it really helps to slow down the velocity of tooth movement on anything that I consider a challenging tooth movement, such as this distalization of this canine. And the planning of the MOPs, there's no reason to go distal to the first molar, and I just use singular MOPs for this because all we need is just to get a little bit of arch form out of this. And so principally, since we're looking to really get good spacing for cosmetic recontouring of the peg-shaped lateral incisors, we've got at least 2 MOPs on each side, all the way. And this is what it looks like. And once again, it's really not out of control. By the time the patient's ready to leave, the hemorrhaging is stopped. They're already on Tylenol. They're not in any significant discomfort. And after 28 aligners and 3 months and 2 weeks of treatment, with the patient following a 3 to 5 day aligner exchange protocol, and that basically after this first month, it's usually 3, sometimes 4 days, especially with those peg-shaped laterals. Then we stopped. We took off all the attachments. We had the patient whiten, and after the patient whitened, we came back and we matched the composite. We just simply went ahead and we built up his lateral incisors with composite recontouring, and then we rescanned him so that we can check the symmetry with another Bolton discrepancy and plan out his finish. And now we're really focusing, we've got the arch form, so we're focusing on creating the best smile arc that we can get, and also getting some canine protected occlusion by extruding the canine. It's another 28 aligners. Since time is of the essence, went through another MOPS. My personal experience is it varies wildly from one patient to the other. MOPS usually last anywhere from 3 to 6 months. So what I find that usually after 3 months, patients are telling me they're starting to exchange the aligners every 4 days or every 5 days instead of 3 days. And I'm fine with that because by that time we're just about ready to wrap up the case. And you can see the majority of the tooth movement, outside of a little finessing of the posterior occlusion, is just to get that smile arc that we're looking for on our patients. And once again, it takes an awful lot of extra aligners to incorporate that smile arc. But now that we've got MOPs as a great adjunctive modality, we're not burning up a lot of treatment time with this. And since on his second MOPs, we've already got our arch formed, there's no reason to go more than distal to the canines. But once again, since I'm focusing, I'm trying to get a good interincisal angle. I'm still retracting the lower incisors, or uprighting them, and getting that interincisal angle within a physiological range, and then getting the smile arc. We're focusing our second round of MOPs simply on the anterior teeth. And you can see the perforations do not go beyond the distal aspect of the canine. And then close to the end, found that the canines were just a little short in terms of making sure that the patient wouldn't engage his incisors in mandibular excursive movements. So we resorted to bootstrap elastics. We put a little ceramic button on the buccal surface of the canine and used some buttons on the back, although nowadays I use Kaplan hooks because the patients don't have any problems getting them, and sometimes they struggle with getting the elastics on the hook, on the buttons. So with the hooks, it's not a problem. And so he just continued finishing up. He's completely finished with the aligner therapy, and we're just finessing the canines. And then when we got them into that into a canine protected occlusion, the lateral excursions, we got the arch form that we're looking for. We got the smile arc, and with a total of 56 aligners, total treatment time is 6 months, 3 weeks in treatment on a 3, 4, 5-day aligner exchange following the second day of Propel. And improved the width just a bit, but more importantly, we got the interincisal angle where we wanted it. Upper incisor to the nasion is in good shape. Facial axis is good. And we were able to upright the lower incisors to empty. And by doing that, I think we're going to have a greater degree of stability in the final result. And you can see we're able to maintain that axial inclination where we're distalizing and closing that space to the canine. And I'd like to talk a little bit about pulse vibration technology in orthodontics. So far, research has only suggested, and I want to be clear, suggested that vibration may have some advantages or some benefits. It seems to be possibly helpful in improving aligner seating. That's been my experience. Has a non-pharmacological analgesic effect in some patients. It's possibly accelerated orthodontic tooth movement according to Alicani, and it's possible enhanced retention with increased bone formation. So to date, there's two principal devices on the market. One is the low-frequency vibration device that vibrates at 30 hertz, and the other is a very high-frequency vibration device that vibrates at 120 hertz. And to date, published studies purported to support the effectiveness of low-frequency vibration. And these are the principal studies that have been cited, although that's been subjected to some criticism. And since it's been followed through, Woodhouse has found when he was followed through on some of those studies, he found no effect with fixed appliances at a low vibration device. Yadov and all have also found that they found no differences at 10 hertz and at 20 hertz. Yadov continues to follow through on this, and he's actually demonstrated a significant decrease in osteoclast number and surface activity when he's used a vibration device at 30 hertz. And Rubin has found that frequencies from 15 to 90 hertz can be strongly anabolic, which is exactly the opposite of what we're trying to do when we're trying to stimulate osteoclastic activity and bone remodeling. And Kalajic and all has found that when he evaluated low vibration forces at 30 hertz in rat molars, now granted the total number was only 9, but he concluded the tooth movement was significantly inhibited by the application of centrifugal forces at a frequency of 30 hertz. But in spite of the lack of science-based evidence supporting accelerated treatment using pulse vibration devices, many respected practitioners have reported significant accelerated results with their patients using a low frequency 30 hertz device. Now, Lewenthal et al. Has found that they've reported a significant acceleration of canine retraction in 15 patients following first premolar extraction. However, they didn't use a pulse vibration device, they used electric toothbrushes. But the key was they were using electric toothbrushes that vibrated at 125 hertz. And they did find a threefold increase in one of the markers, the cytokine markers associated with strong osteoclastic activity. And Judic et al. Also reported that bone morphology changes are significantly greater at 90 hertz than at 45 hertz. And of course, Alakani, who's been the fourth in terms of research with high frequency devices, has found that he gets higher bone formation effects that are produced at higher vibrations around 120 hertz. So to date, high frequency device that is recommended for improved aligner seating and reduced aligner lag. And I found that to be a significant advantage in my own practice. There is no claim, however, of accelerated tooth movement. But by virtue of enhanced aligner seating, my own personal experience has been it clinically reduces both refinements and treatment time in aligners, especially since so many of my patients will sometimes just not wear their aligners for a couple of days. And previously, before these devices became available, that was an instant refinement for me. But now with these using the aligners plus the pulse vibration device, I just had them use the device until they regain their tracking before we move on. And it's been a real advantage in my practice. So at the beginning, I was starting to use the devices when we were still exchanging the aligners every 2 weeks. But regardless, this would have been problematic for me before using a device. And by using the device and having exchanged the aligners every 7 days, we got a very reasonable result in 10 months and 3 weeks of treatment. But once again, then it loads the question of, geez, could she have gotten the same result with just exchanging aligners every 7 days with this new protocol and the new material that Align uses without a high frequency vibration device? Because she was a very cooperative patient. So it leads to the question of, if high frequency vibration does in fact have the potential to accelerate treatment secondarily by virtue of its enhanced aligner seating capacity, would it be possible then to exchange these aligners even more frequently than the current 7-day protocol that's been promulgated by Align Technology? And for this, I just follow the lead of Dr. Tom Schiffley, who had started exchanging aligners every 5 days with pulse vibration. And so I thought that, in selected cases, I started using that 5-day protocol. And this is one of my first cases. And once again, she had a lot of times my aligner cases are just simply previous orthodontic treatment where they were unable, especially on a lot of these cases where they come in with inadequate incisal guidance and they start getting headaches. And so when they start getting symptomatology, there's reason to go in there and try to get a smile arc, but also try to get some incisal guidance and improve their interincisal angle. So that's a lot of aligners because, once again, I'm slowing down the velocity of tooth movement to ensure a tracking. So, and the reason why I manipulate the velocity is I want to do everything I can so I don't have to resort to bootstrap elastics or to refinements. And you can see, once again, I'm using the Nicosis extrusion protocol to affect the treatment and to maximize my opportunities for tracking throughout the entire treatment. And it's worked out very well. So we were able to complete the treatment in 5 months and 3 weeks, and she was able to exchange the aligners every 5 days using just a high-frequency vibration device, 5 minutes a day. And a lot of you are familiar with my phase 1 to Invisalign. Do a lot of phase 1 because I have to admit that if this was 10 years ago, I'd probably be looking at this as a 4 bicuspid extraction case. But now with being able to use the Bolton analysis and being able to use interproximal reduction, I'm not as quick to remove bicuspids, although I have nothing against taking out bicuspid teeth. We get the arch form, and we use DMAX from Dynaflex to distalize to create more room to get canines in. And at this point, I'm distalizing so I can reduce the number of aligners in phase 2 treatment. So at this point in treatment, I would actually take out these appliances. I would go ahead and scan the patient for Invisalign. Aligners come back, and then we start our Invisalign treatment with a pulse vibration device that's high frequency. And you can see that this is only the first round. There will be refinement because the canines aren't in. So at this point, I'm trying to establish the arch form and start working on the interincisal angle. And now I've already got the space, so I can distalize this, and I can blow a little anchorage there and support it with class 2 elastics off the 4s because the 3s are not in. Allow the 3s to drop in. And now she's ready for refinement. I've already got the arch form. I still have to improve the interincisal angle with additional IPR. And now we've got another 35 aligners because now I'm focusing on the Nicosis extrusion protocol, trying to create a nice smile arc, doing additional IPR so that I can improve her interincisal angle and reduce the procumbency without removing bicuspid. Vertical attachments here in these eyes are just to get some axial inclinations of the improvements in the lower incisors. And one of the reasons why there's so many aligners is because this tooth came at a very poor axial inclination. So I've got a vertical attachment to get as much axial inclination correction I possibly can in this case without using any auxiliary. And with a total of 60 aligners, we're able to complete the case in 12 months and 3 weeks. And she used a 5, 6, 7-day aligner exchange program, and with mostly every 5 days. And we got a very reasonable result. And I think I'm pretty happy. In fact, I think I almost overcorrected this a bit, but I'm happy with the relative root parallelization of the teeth. We were able to get this interincisal angle into the normal physiological range, improved her width, and got good facial axis, and the upper incisor to nasion is spot on. And more importantly, I'm very pleased with her facial profile. She's got beautiful full lips. And so after having used both the devices, I started using combinations for ridiculous cases. And this was an individual that came in that nobody wanted to touch him because of the problem that he has with all of this recession. And on these cases, I tell him I'm not going to do this case unless I do MOPs and pulse vibration. And the reason why is I want to, on every single tooth, I want to slow this down to 0.15 millimeters per aligner to allow the tissue to compensate for this and to move forward. So it means it's going to be a lot of aligners. 75 aligners for his first round. We were able to complete this in 10 months. And the only reason why we stopped, because I knew that we were going to have to stop and take off all the attachments. The patient had to go ahead and whiten, and then he had to go in and get restorations because there was decay that was evident there, and we wanted to get these teeth out in the open so that the dentist could do a better job. I think previous dentist did the best he could with the crowding that he had to deal with, but now he can get in there and get some very good, reasonable contours. So now he's still in treatment. This is another case. I told obviously she had orthodontics previously. There was a lateral incisor missing, so there was a canine substitution. But because of the strong class 3 and with the vertical component there, she's got quite the overbite. And I said I'd be glad. And obviously these patients cannot submit to surgical orthodontic treatment because they just don't have the finances. So the key is to do what we can to improve her situation. But I told her, I said, I'm not going to do this without MOPs and without high-frequency vibration device. So she acquiesced to that and got her going. And after 45 aligners, we're 11 months into treatment, and we have a significant degree of improvement. And could have done better, I think, if I would have put this Kaplan hook back on the 7th, but she couldn't reach back there. So I find that a lot of times I have to get some type of improvement going 6 to 4 or 6 to 3. And once they get used to it, then on what we're doing right now in her refinement, so we move the Kaplan hook to the 7th. Now we're going 7 to 4 to get more class 3 improvement and get some more lingual root torque on this and move forward. So how do you monetize all this treatment? Well, for MOPs, we, we go 200 to 250 per quadrant. If we're only doing a single quadrant, for example, just going 3 to 3 on a maxillary or 3 to 3 on the lower, so we charge a $300 fee. For the high vibration device, we charge $600. If we're doing a combination, we're going now between 1,100 and 1,200, and just roll that into the orthodontic fee, and just put them on auto pay. So there's enough science-based evidence as well as extrapolation from corticotomy and from piezo-excision data, together with both clinical trials and clinician experience, to acknowledge that accelerated orthodontic devices probably have a place in orthodontic treatment. I think they have a significant place. Now, MOPS, in my personal opinion, currently represents the gold standard of acceleration modalities due to its proven clinical ability to accelerate clear aligner treatment in general, and due to the fact that its acceleration effects, unlike pulse vibration, are not predicated on absolute patient cooperation. In spite of numerous articles supporting acceleration, there is a clear lack of science-based evidence to definitively support claims that acceleration is effective. Accordingly, practitioners are left to the significant reported clinical results of respected clinicians who have experienced success with their patients as a guide to whether or not they elect to incorporate these modalities into their own practices. And having personally appreciated the benefits of accelerated orthodontic devices in my own practice, I would at least encourage clinicians to evaluate these devices for their own orthodontic treatment procedures. So I appreciate the opportunity to speak with you. I thank you for your attention, and I'll take any questions at this time. All right, we have a question from Dr. William Dabby, and he said, do you change your fees if using these products? Or is it time saved with appointments covering your costs? I have to tell you, now that I've been doing this for a while, sometimes when patients say they can't afford it, I will give it to them anyhow, because my whole focus is on getting the best results that I possibly can and getting out of treatment. At least here in Scottsdale, patients just, they actually burn out. They burn out much more quickly than they did before. So my focus is on acceleration. But I have found that patients are more than willing to pay these fees as long as you make it feasible for them. So what I do is I put everyone on auto pay, and it matters not to me if they finish their treatment before they finish paying their fees, because I'm still following them in treatment through retention. So that's a good question. Thank you. And then another question is, do you use dental monitoring to track seating of aligners before changing trays? I'm not quite sure what you mean by dental monitoring, but I can tell you that the most important thing in my own practice is making sure that patients understand what good tracking is. I tell them that if you have any doubts, take a selfie and text it to me, so let me be the judge. And I have to tell you that to date, no one has done that, because I think that's just a reflection of the fact that my staff is very good about making sure that the patient doesn't leave the chair until they understand what good tracking is. And Stratty, thank you for your comments. I really appreciate it. And thank you, Mel Pearson. Great to hear from you. And Mark Wong asked, is this being recorded and available online for review? And the answer is absolutely yes. After I finish this, this will be available for review. And again, it says, thank you for the presentation. How different is this for patients with periodontal disease? Well, first of all, I'm not starting patients with periodontal disease unless they've gone through a significant regime with a periodontist. Now, as far as patients with significant bone loss, I'm not as reticent to start these patients as long as I slow down the velocity of tooth movement, because I find that the patients do find, as long as they're under the care of a periodontist, they're getting their cleanings every 3 to 4 months according to what the periodontist wants, and we move forward in that direction. But I'm getting a little bit bolder now that I'm getting a significant degree of success with these patients. But once again, I want to be clear. If they've got, and I tell patients, orthodontics works great in healthy tissues. It doesn't work very well in diseased tissue. And I want to make sure that they understand that, and they're under the care of a periodontist. So that seems to be all the questions. And once again, I appreciate your attention, and it's great to see so many familiar faces. and thank you for your kind remarks, and I hope to see you in the future.